Hello everyone. Hope I am audible and visible. Here are we. Target FMGE. Yes, December FMGE should be our target. And here myself, Dr. Sanjay Khatri, I am coming with some most important topic, an MCQ in pediatrics. Before that, something about Unacademy. What Unacademy is doing to strengthen your preparation for FMG. You can see daily classes of the top educators there on Unacademy app. Note down the date from 25th to 31st August. All are free and special. So yes, special learning week. Special learning week. Now, if you want to target FMG, this is the time for you. Ultimate revision. Trust, trust, trust. Faculty of Unacademy. Okay, so just target 150 plus in FMG December 2023. So 150 plus hour high yield practice covered in live session. I mean it, live session. Rapid revision, test and discussion, doubt clearing session. We all are here for you. What you are waiting for? Subscribe it in 5600 and use the code Dr. Sanjay Live. Okay. Wait, no. This is the time to take Unacademy. Unlock the power of learning. Get 20% off on all Unacademy subscription valid till 25 August. Now, if you want to head further, so it is iconic subscription for you. Witness the Unacademy Plus live batches, notes and mentoring session for you. Yes, whatever problem in learning, how you schedule your batches, how you schedule your courses, everything will be taught to you. So yes, in this Unacademy Plus, you can see the live course plus recorded. This is the time. Yes, iconic subscription. Now come to the topic. So here we are discussing. So what is this? Mother has worried her child not pass urine on postnatal day 1. Means postnatal day 1, child not pass urine. So what advice you give to mother? What would be the next step of management? Anybody? Yes. Smriti is right. So everybody is right. Renu is right. Murguniya is right. So yes, normally, baby can pass stool within 24 hours. Normally, neonate can pass urine within 48 hours. Here, the first postnatal day means 20 hour, 22 hour, 23 hour. Baby not pass urine. Baby not pass urine. So yes, it is normal. If not pass urine, we can wait till 48 hours. So baby can pass. No worry, nothing. So you advise mother, continue breastfeeding and observe. Not pass urine in first natal day. No worry, we wait till 48 hours. Normally, neonate pass urine within 48 hours. Stool 24 hours. Suppose baby is 26 hours, not pass stool. Then we need to worry. We need to investigate what will be the cause. But yes, urine we can wait till 48 hours. So these are some basic questions. But this question was last year in NEET PG. So maybe any time in FMG. So just a basic question. Urine we can wait till 48 hours. Answer this question. This question comes so many times in different format. What hematological abnormality you suspect if child born with bilateral absence of radii? Answer. Yes, you can suspect TAR syndrome. First thing, if you notice child is with absent radius, first thing you order platelet count. And rule out this is not thrombocytopenia. If absent radius with thrombocytopenia, then it is TAR syndrome. Absent radius with thrombocytopenia, It's TAR syndrome. Okay. Now, one more thing I want from you. Child is having eczema plus thrombocytopenia. What syndrome you are suspecting? Eczema plus thrombocytopenia. What syndrome? Yes, please answer it. Absent radius thrombocytopenia, TAR syndrome. Eczema, thrombocytopenia, which syndrome will be there? Yes, yes, yes. It is Wiskott-Eldridge syndrome. Was Wiskott-Eldridge syndrome. Very good. Very good. So I can ask some more question to you. Okay. Low platelet, a child born with hemangioma plus low platelets. Hemangioma plus low platelet. Which syndrome you are diagnosed? Anybody? Hemangioma and low platelet. Yes. KMS. Casaback Merritt syndrome. So absent radius thrombocytopenia, TAR. Thrombocytopenia, eczema, was Wiskott-Eldridge syndrome. Thrombocytopenia, hemangioma, Casaback Merritt syndrome, KMS. These all are probable question for upcoming exam. Answer this. So I will know you this. You should know this concept. ABO incompatibility. So answer. I will wait for your answer. Yes. Wasim, Arush, Doc, Renu, Brinda. Answer this question. Jaundice due to feto-maternal incompatibility is more severe when? Now see. Suppose anybody's blood group is A. Which antibody is there? Anti-B. Anybody blood group is B. Which antibody is there? Anti-A. If anyone blood group is AB, what antibody is there? Nil. If anybody blood group is O, what antibody is there? Anti-A, anti-B. Clear, na? Clear. Okay. See the first scenario. See the first scenario. Mother blood group is A. Slowly. Mother blood group is A. Suppose father blood group is B. First scenario. Father blood group is B. So it may possible baby blood group is B. Fetus blood group is B. Okay. Second scenario. Where mother blood group is B and father blood group is A. Suppose father blood group is A. It's not written here. When father blood group is A in a B situation, fetus blood can be A. What we have written, mother is A positive, contain anti-B antibody, and baby is B. This anti-B is going to destroy this B. This anti-A is going to destroy this A. No, it's not possible. Why? Because these two antibodies are IgM type. They not cross the placenta. So if mother blood group is A, baby is safe in terms of jaundice. B, again safe. AB, definitely safe. Now see, if mother blood group is O, which contain both antibody, anti-A and anti-B. Now, if baby blood group is either A or B, this is going to destroy. Why? Why? Because in O blood group mother, these both antibodies are IgG type. They can very well cross the placenta. This is known as ABO incompatibility. ABO incompatibility, where mother blood group is O, baby blood group is either A or B. Whatever the blood group, O mothers contain both antibody anti-A and anti-B. It will destroy either blood group is A or B, either A or B. Then what we say, in which jaundice is more? See, anti-A is more powerful than anti-B. What it means? Anti-A is more powerful than anti-B. What it means? Suppose anti-A destroy 100 RBC, so anti-B will destroy 80 RBC. Now think. When anti-A will come into action? When mother O and baby A. Then only anti-A will come in action. When anti-B will come in action? When mother O and baby B. So when jaundice is maximum? When mother O, baby is A. So yes. Renu is want to know why not? Mother O, if baby is AB, both can destroy. Yes, Renu, both can destroy. Practically not possible. Mother O, baby can't be AB. So, Renu, your answer would be mother O and baby A positive. Ashok, good evening. Got it? Am I right? You got it? Jaundice due to feto-maternal incompatibility is more when mother O and baby A. Am I clear? Have you got it all clear? Jaundice due to feto-maternal incompatibility more severe when mother O and baby A. Clear? Clear? Answer this question. So first, you need to know the concept of ponderal index, formula of ponderal index. Ponderal index formula. Weight in gram upon height in centimeter cube into 100. What is the weight? 2. So it is 2 kg. We need to convert into gram. So it is 2 into 1000. Height centimeter cube. What is the height? 50 centimeter. 50 into 50 into 50 and into 100. Simple maths. No need to afraid. No need to afraid. Simple maths. 1 0 1 0 1 0 1 0 1 0 1 0. It will come 200 by 125. It is 1.6. Yes, it is 1.6. Ashok, Arush, you are very fast in mathematics. Okay, so see, answer would be 1.6. What is the utility of Pondal index? Pondal index is less than 2 in asymmetrical SGA. Pondal index 2 or more than 2 in symmetrical SGA. IUGR. So yeah, remember the formula of Pondal index. When we go to exam, we forget its weight in kilogram or gram. It's weight in gram. Height in centimeter square or cube. It is cube. So just my sincere request, just revise this once more within 10 seconds. Formula of Pondal index, weight in gram upon height in centimeter cube into 100. Clear? Clear? Such a big question. No problem. Read this question. Read. You have to read. I will wait for your answer. Read. I want to practice you long history based question. FMGE exam is now not less than, they are asking so many clinical question, long history based question. This question is really check your patience, how you read it. I will show you. Infant weighing 1400 gram, born at 32 week, means it's a preterm. Evaluation was benign and infant was referred to level 2 nursery for prematurity, just for prematurity. The nurse there call at 1 hour of life and report infant is tachypneic. Means respiratory rate is more than 60, tachypneic. Vital sign, heart rate is 140, respiratory 80, temperature 35 degree, peripheral oxygen saturation 98%. Lungs are clear. Bilateral breath sounds, there is no murmur. Infant has no distress. Radiograph shown. Which of the following is most appropriate next step in evaluating the infant? So why you want to give oxygen when saturation is normal, X-ray is normal? Why you want to do blood count, no fever, no sepsis, no dullness, no convulsion? Why you want to give glucose? Even this could be your approach, but more simpler. If you notice na temperature is 35 degree, 95 degree Fahrenheit, baby is hypothermic. Preterm baby, hypothermia is common because brown fat is less. That's why the initial treatment, put the infant under radiant warmer. Now, this is the question for you. Okay, all big clinical questions are not tough. Some are very easy like this. You can't judge this is a INI-CET question or FMG question or NEET PG question. This is practically a simple question. You can need to pick the hypothermia is there and you need to put the baby under radiant warmer. So normal body temperature of a neonate 36 to 37, 36.5 to 37.5. Hypothermia less than 36.5. Cold stress 36 to 36.4. Moderate hypothermia. Our patient is in moderate hypothermia. Severe hypothermia is less than 32. Our patient temperature is 35. 32 to 35.9. It is moderate hypothermia. Am I clear? So yeah, you need to pick from the question what is abnormality. Do not afraid from a history based question. X-ray is given, it doesn't mean X-ray is always abnormal. Sometime examiner it's over smart. Okay, so this you can't say sorry this is very tough question. This is such a simple question. You need to pick. Answer this. This is memory based question. Answer this. Which of the following is not correct? So human breast milk, cow milk contain equal percent of water. Yes, both contain 88% of water. A is right. Human breast milk and cow milk contain equal amount of fat. Yes, breast milk contain fat 3 to 3.5. Oh, sorry, 4 to 4.5 and cow milk also contains same fat. But the difference, breast milk contain more polyunsaturated fatty acid. Cow milk contain more saturated fatty acid. So polyunsaturated fatty acids are good for brain growth. So A is right, C is right. Water is equal, fat is equal. Now, human breast milk contain more carbohydrate. Yes, 6.5 to 7 as compared to cow milk 4.5. More carbohydrate. So B is also right. Then we left with the C. Human breast milk contain more protein as compared to cow milk. So look like D is also right. Breast milk contain more protein. Yes, we can say breast milk is the good ideal food. So it may contain more protein. Actually not. Breast milk contain 0.9 to 1.1 gram protein per 100 ml. Cow milk contain 3 to 3.3. Yes, breast milk contain less protein, But breast milk protein is of good quality protein. Why? Casein ratio. Easily absorbable, easily digestible. So always remember, protein is less in breast milk, but it's a good quality protein. Water equal, calorie equal, fat equal, but fat more polyunsaturated. Carbohydrate definitely more in breast milk. So if you are going for exam, remember this table. Remember this table. Calorie, breast milk 70, cow milk 67, water 88%, breast milk, cow milk, protein 0.9 to 1.1, cow's milk 3.3 to 3.5. Why? Casein ratio 70 is to 30. Why? Casein ratio 70 is to 30 in breast milk. Cow milk, it reverse. If Y is more, milk is easily digestible, easily absorbable. Fat, more polyunsaturated fatty acid. Cow milk, more saturated fatty acid. Carbohydrate is more in breast milk. Breast milk is the ideal gift a mother can give to the baby. Baby is on breastfeed, protected with respiratory diseases and diarrheal diseases 10 to 15 times as compared to those who not receive the breast milk. So good for brain growth, polyunsaturated fatty acid. So we make all effort. Mother baby should get mother milk, either direct breast milk or expressed breast milk. So breast milk you need to remember, because pediatrics question can come in any exam from the breast milk. Answer this question. Answer. 2-month baby present with history of jaundice, turmeric color urine, and pale stool since birth. So what is this? What this history indicate? Jaundice is there, okay? Jaundice is there. But whether it is conjugated or unconjugated, history wise, if baby pass dark yellow color urine, dark yellow, or you can say turmeric color urine, and pale white stool, pale white stool, we suspect it is conjugated jaundice, conjugated hyperbilirubinemia. Unconjugated, urine is yellow, not dark yellow. Stool is also yellow. It's not white. But see this point, whenever you saw a patient of jaundice, 1 month, 2 month, 15 days, just ask, what is the color of stool? Mother say clay color, pale stool, white stool. You suspect you are dealing with conjugated hyperbilirubinemia. Mother will tell you, urine is so yellow, so yellow, so yellow. How urine is so yellow in conjugated hyperbilirubinemia? Try to understand the concept. This is the liver. This is unconjugate bilirubin. When it convert into conjugate bilirubin, then only it excrete into the bile. While excrete into the bile, it come into conjugate bilirubin will come into intestine, and this bilirubin will be acted upon by bacteria, which convert conjugate bilirubin into stercobilinogen and urobilinogen. Stercobilinogen in stool and urobilinogen in urine excreted. Stool color is yellow because of stercobilinogen. Now, what happened? Bilirubin is conjugated. Bilirubin is conjugated. Now, this conjugate bilirubin is not able to excrete in bile. What happened? Conjugate bilirubin will spill into blood. So why? Two common cause. One is hepatic cause. Another is extrahepatic. Now you are clear. One, it is hepatitis. Neonatal hepatitis, where hepatocytes not allow conjugate bilirubin to excrete into bile. And second, there is bile duct atresia. Both the situation, conjugate bilirubin will spill into blood. Instead of going into bile, conjugate bilirubin spill into blood. It is water soluble. Conjugate bilirubin is water soluble. So it excrete via kidney. It excrete via kidney. So that gave urine dark yellow color. Now, conjugate bilirubin excreted via urine. It will not come in the bile. It not come in the gut. So stercobilinogen will not be there. When it not be there, stool is pale white. Am I clear to you? Give me a thumbs up. Am I clear? Clear. Conjugate bilirubin, unconjugate bilirubin. Bilirubin get conjugated, but not able to excrete through bile. It will spill into blood, and jaundice is known as conjugated hyperbilirubinemia. Conjugated hyperbilirubinemia. Why conjugated hyperbilirubinemia? Urine is more yellow. This is the reason. Why stool is pale? This is the reason. Now, we have to differentiate whether we are dealing with neonatal hepatitis or biliary atresia. Whether we are dealing with neonatal hepatitis or biliary atresia, this question come in exam from ages. To differentiate these two, investigation of choice, liver biopsy. Investigation of choice, liver biopsy. Liver biopsy. 2-month baby present with history of jaundice, turmeric colored urine, pale stool since birth. History of jaundice, turmeric colored urine and pale stool since birth. Liver is enlarged. Investigation of choice, establish the diagnosis. We are seeing it's a conjugate hyperbilirubinemia. But to establish the diagnosis, whether it's a biliary atresia or neonatal hepatitis, we need to do liver biopsy. We need to do liver biopsy. Clear? Clear? This is very good question. Asked so many times in so many different format. Sometimes they ask to give you just history. It can be which of the following. So you need to choose which of the following. If this history, this belong to biliary atresia. Okay, it's not hypothyroidism. It's not hemolytic anemia because pale stool, dark turmeric colored urine. And when they want to which test to establish the diagnosis, it will come liver biopsy. It will come liver biopsy. Answer this question. Answer. Simple question. Live vaccine. Such a simple question. Which are the live vaccines? So, live vaccine, you have a wonderful mnemonic. Mamas, we are mama's boy. We are mama's boy. V for varicella. R for rotavirus. M for measles. M for MMR. B for BCG. O for OPV. And Y for yellow fever. We are mama's boy. So here mama's measles is one, boy yellow fever is one, and varicella is one. So your answer would be 1, 2 and 5. 1, 2 and 5 is there in A. So why Renu you put answer B? Arush B. B is 1, 4, 5. Influenza is not the live vaccine. Answer would be, Brinda is right. Answer would be A. So live vaccine, you need to remember, we are mama's boy. See here. This diagram you need to remember. We are mama's boy. These are live vaccine. Varicella, rotavirus, MMR, BCG, OPV, yellow fever. So influenza virus, remember like this, killed vaccine. Harry. Hepatitis A. R for rabies, I for influenza. Harry. H hepatitis A. HA hepatitis A. R for rabies, I for influenza. Now recombinant vaccine. Hepatitis B. What are polysaccharide group vaccine? Polysaccharide group vaccine. Hib, pneumococcal, meningococcal, typhoid. Hib, pneumococcal, meningococcal, typhoid. And what are toxoid? Diphtheria and tetanus. Can you believe? This was the question in AIMS 2020 June. Which of the following is a toxoid vaccine? Diphtheria. Diphtheria, tetanus is a toxoid vaccine. So this is universal table. Live, killed, recombinant, polysaccharide vaccine and toxoid group of vaccine. Spend just 2 minutes on this table. Remember what are the live, what are the killed, what are the subunit, and what are the toxoid vaccine. No problem, Arush. We are learning here. Now you will never forget in your life. Live vaccines are we are mama's boy. Killed vaccines are Harry. Hib, pneumococcal, meningococcal, typhoids are polysaccharide vaccine. Diphtheria and tetanus, toxoid group of vaccine. That's why I intentionally put this question. Just because multiple choices. Suppose I ask this question, all of the following are live vaccine except which of the following is killed vaccine except, you can answer it. But to make question more difficult, applicable to every exam, multiple choice. Okay. So whatever you are preparing for FMG, NEET or INI-CET, this is the must know question. Okay. So live vaccine, killed vaccine, polysaccharide vaccine, toxoid group of vaccines. Okay. Shall I move? Answer this. I want answer from your side. Little bit. 30 second think. Handedness. One is going to right-handed or one is going to be left-handed. When we come to know handedness determined by Smriti, Renu, both are right. By 3 year. Means by 3 year, 36 to 42 month, we come to know this is righty or this is lefty. Suppose 18-month old baby, 18 month, preferably using the left hand. Preferably using the left hand. It means something wrong in the right hand. Else 18 month baby can't use till 3 year, baby can use both hand with equal preference. Baby can use both hand with equal preference. One should be right handed or left handed, earliest determined by 3 year. So correct answer is handedness, usually determined by the age of 36 to 42 month. 36 to 42 month. Am I clear? Clear? Handedness usually determined by the age of 36 to 42 month. All primary teeth erupt by the age of. See, primary teeth are 20. Secondary teeth are 32. So, examiner want to know all primary teeth erupt by the age of. Now see, any clue? This is central incisor. Am I clear? This is central incisor. This will be lateral incisor. Central incisor erupt by the age of 6 to 8 months. Lateral incisor 8 to 10 months. Slowly, slowly. Central incisor, lateral incisor. Then come the molar one. Molar 1. Molar 1 erupt by the age of 10 to 16 months. Slowly, no worry. Then come the canine. 16 to 20 months. Then comes molar 2. 20 to 30 month. 20 to 30 month. Molar 2. Now listen carefully. Listen, see on the screen. This is central incisor. This is also central incisor. This is also central incisor. This is also central incisor. Okay, so one tooth represent 4 teeth. Now see, central incisor 6 to 8 month, number of teeth will be 4. Lateral incisor 8 to 10 month, number of teeth will be 8. Molar 1 10 to 16 month, number of teeth will be 12. Canine 16 to 20 month, number of teeth become 16. When second molar come, molar 2, 20 to 30 month, number of teeth become 20. So all primary 20 teeth erupt by the age of 2.5 year or 20 to 30 month. Am I clear? If any confusion, put in the comment box. Dental age. First central incisor 4, then lateral incisor 4, then molar first 4, then canine 4, then molar 2 4. All 20 primary teeth erupt by the age of 20 to 30 months. Am I clear? All primary teeth erupt by the age of 2.5 years. Clear, na? Now you can answer this question. What is the correct sequence of eruption of primary teeth? Central incisor, first molar. This is not true. Central incisor, lateral incisor, canine. This is also not true. First molar. This is also not true. We left with the third one. Central incisor 6 to 8 month, lateral incisor 8 to 10 month, first molar 10 to 16, then canine 16 to 20. So now you are clear in determination of dental age. Something you are learning. How we interpret the dental age. Am I clear? Am I clear? What is the sequence? All primary teeth erupt by the age of 2.5 years. Clear? Answer this. Nirmala, you need to remember vaccine with their strains. Vaccine with their strain. Injectable polio, Salk. Oral polio, 7. This we always remember. BCG is Danish, 1331. We always remember. Chicken pox is Okai strain. We always remember. Measles, Geryl Lin strain. It's not Geryl Lin strain is for mumps. For mumps. Okay, so A is not right. You need to remember the strains. See, BCG, Danish 1331. OPV, as I told you, 7. IPV, as I told you, SAC. Mumps, Geril Lin strain. But here in question, it is written measles Geril Lin strain. This is not correct. Geril Lin strain is for mumps. Geril Lin strain is for mumps. Clear? What is the strain for measles? Yes, yes, it's Edmonston Jebre strain. Edmonston, AZ. Very good. Arush is good, fine. AZ strain. Rubella, you will remember RA27 by 3. Rubella from RA27 by 3. You can remember. Chickenpox, we always remember Okai strain. Now these two are difficult. Japanese encephalitis. Sometime I also forget. SA 14 Japanese encephalitis. SA 14 and yellow fever 17D. And yellow fever 17D. No one, no way. You need to remember. No else will remember for you. You have to remember this thing. Vaccine and their strains. Vaccine and their strain. And you may get a question, which of the following is not a correct match? Which of the following is not a correct match? You will get this question. So clear? Clear? Vaccine with their strains. Vaccine with their strain. You need to remember this table. BCG, Danish 1331, OPV 7, IPV SAC, mumps, Geryl strain, measles, EZ strain, rubella, RA27 by 3, Japanese encephalitis, SA 14 varicella oca, and yellow fever 17D. Clear? Oh, answer this question. I will wait for your response. Answer this question. No hurry. Read this. Don't see the comment box, what other is writing. If you answer na, whether it's wrong, it will remain in your mind for long. Yes, Renu, Ashok, Nirmala, Ovis, Brinda, Arush. What would be answer? A 2-year-old child has been well except for fever. 4th day develop erythematous maculopapular rash. So first thing come in our mind, 4th day rash. 4th day rash comes in measles. Fourth day rash comes in measles. So answer would be measles. Classical history of measles. First day running nose cough, slight 99 fever. Second day running nose cough increase, fever 99. Third day cough, running nose same, fever 99. Fourth day rash appear over body. Fourth day rash appear over body. Fourth day rash, measles. But the key point of measles, as rash appear, fever shoot. Parents come to you, sir, my child is having right mild fever, running nose cough since 3-4 days. Today is the fourth day. Today rash come all over body and fever is 100, 304. As rash appear, fever shoot. Read the question. As rash appear, temperature returns to normal. It can be anything, but it can't be measles. Because measles, fever, rash, fourth day. But when rash appear, fever shoot. But here, as rash appear, temperature returns to normal. It is classical of roseola infantum, also known as sixth disease, caused by human herpes virus type 6. Human herpes virus type 6. Sixth disease caused by human herpes virus type 6. In this, rash appear on fourth day. As rash appear, fever comes to normal. It is roseola infantum. Measles and roseola infantum, both rash come on the fourth day. But measles, as rash appear, fever shoot. Roseola infantum, as rash appear, temperature returns to normal. Human herpes virus type 6. Yes, yes, yes. So, this is sixth disease. Anybody in the comment box put me what is fifth disease? What is fifth disease? Anybody in the comment box? What is fifth disease? This is sixth disease. Yes, I am waiting. Yes, parvovirus. Okay, but what is the name of the disease? Erythema infectiosum. Erythema infectiosum is fifth disease. It is caused by parvovirus B19. Parvovirus B19. So this is sixth disease, about fifth disease, about measles, about roseola infantum. Now read this question. You will enjoy it. Read this question. 4-year-old child present with fever, running nose, conjunctivitis, cervical lymphadenopathy, chorea. 2 times this question in FMGE exam. 3C. Measles, 3C. Conjunctivitis, cervical lymphadenopathy, chorea. Gray lesion surrounding erythema on buccal mucosa. These gray lesions are known as Koplik spot. Generalized blanching erythematous rash, also noted on fourth day. As rash appear, fever rises. What is this? Measles. Measles. Classical history of measles. No, don't run your brain here and there. Yes, how can sir ask such a simple question? This is measles, yeah. Fourth day rash. As rash appear, fever rises. 3C is there. Conjunctivitis, cervical lymphadenopathy, chorea. It is measles. Yes, opposite second molar. Nirmala, yes. Coplic spot. Clear? Answer this. Answer this. Feature of marasmus. I'm waiting for your response. D. Hepatomegaly is a feature of kwashiorkor. Anorexia is a feature of kwashiorkor. Hair changes again is a feature of kwashiorkor, that is flaxine. Irritability, yes, this is a feature of marasmus. Edema is again a feature of kwashiorkor. Anorexia is a feature of kwashiorkor. What happened in marasmus? Voracious appetite. Marasmic kid have voracious appetite. Then why child become marasmic? Because of poverty, not able to get food. Not able to get food. So you need to remember marasmus and kwashiorkor, all the features. You may find question in the exam about marasmus and about kwashiorkor. About marasmus and about kwashiorkor. This is marasmus. First point, weight less than 60% of expected. Suppose 1 year weight is 10 kg. In marasmus, 1 year weight is less than 6 kg. 1 year old child, weight 5.5, 5.8, it is marasmus. Second, mid-arm circumference less than 11.5 centimeter. Previous FMG question. Yes, when we called it severe PM, when MSC is less than 11.5, 11.5. Severe wasting, child appear thin, body is made up of skin and bone, no fat is there. See, all the ribs are prominent, body is made up of bone. Fourth, old little man appearance, wrinkled skin, buccal pad of fat loss. So these 4 points give you a classical image how marasmus kid look like. Weight less than 60%, MSC less than 11.5, body is made up of bone and skin, no fat, old little man appearance. By this you can imagine how marasmic kid look like. African kids on TV, childs on beggars, railway station, platforms, marasmic kid. These four give you image, but fifth and sixth will help you to solve the MCQ. Marasmic child is always irritable and having voracious appetite. All are the feature of marasmus except you will find dull child. No, marasmic kid is irritable. You will find anorexia. No, marasmic kid have voracious appetite. So just this 6 point of marasmus you remember. So we move. Okay. Now answer this question. Marasmus question we have done. What about kwashiorkor? What about kwashiorkor? Kwashiorkor is diagnosed in growth retarded children. Edema and mental changes. A is right because kwashiorkor has essential and non-essential feature. Essential and non-essential feature. Without essential feature, you can't diagnose kwashiorkor. So essential feature first is growth retardation. Second is mental changes. Third is edema. I will show you written everything. Essential. So you can't diagnose kwashiorkor in the absence of essential changes. Kwashiorkor, you have always growth retardation. Weight is 60 to 80% of expected. 1 year weight is 10 kg. Suppose 1 year if weight is 7 kg. This is kwashiorkor. This is kwashiorkor. Growth retardation. Mental changes. Child is dull and apathic. No interest in surrounding, doesn't play with the toy. No interest in surrounding, doesn't play with the toy. Apathic child, dullness, and edema is there. So to make the diagnosis of kwashiorkor, you need these three: growth retardation, mental changes, edema. So kwashiorkor diagnosed in growth retarded children along with edema and mental changes. Somebody will confuse mental changes. No, it's dull, apathic child, no interest in surrounding, doesn't play with the toy. Answer is A. So what are the non-essential changes which may or may not present in kwashiorkor? May or may not. Those are hair sign, flag sign. This is the hair. On hair, you find alternate band of pigmented and depigmented zone. Alternate band of pigmented and depigmented zone. Skin changes. Flaky paint dermatosis. On skin, you find hyperkeratotic patches. Flaky paint dermatosis. Others: hepatomegaly, fatty liver, anorexia, chillosis. Hepatomegaly is a feature of kwashiorkor. Fatty liver is a feature of kwashiorkor. Anorexia and chillosis. So yes, this question can come. Hepatomegaly is not a feature of marasmus. We are reading pediatrics. PM is the most important topic. Marasmus, kwashiorkor, you find n number of question in any of the exam. So marasmus and kwashiorkor. Clear? Answer this question. Male child delivered to HIV infected mother. So mother is positive and baby deliver. Baby deliver. So if mother is positive, what is the chance baby will be positive? 15 to 40%. If you start retroviral therapy to the mother, chance baby will be positive is less than 3%. Less than 3%. Okay, now see, from mother to baby, transmission occur via in utero, during delivery, while breastfeeding. In utero, risk of transmission is 30 to 33%. During delivery, 60 to 65%. Via breastfeeding, 1 to 5%. Question will come. Transmission of HIV from mother to baby maximum occur at the time of delivery, when baby passes through birth canal. When baby passes through birth canal, that time maximum risk of transmission occur. That's why if mother is positive, we preferably do cesarean section. Now see, mother is HIV positive, delivered to a baby. Mother receive antiretroviral therapy throughout pregnancy. Chance less than 3% baby will be positive, or we can say more than 97% baby will be negative. So what, this is the biggest question in front of treating physician, mother or family. So what test, which is the most sensitive test? HIV DNA by PCR is the most sensitive test to detect HIV in a baby who born to HIV positive mother. This is the most sensitive test. Culture we can also detect, P24 antigen we also detect, but culture take long time to get positive, and HIV P24 antigen false positive results are there. So HIV DNA by PCR is the most sensitive test. This question come once. Another question come twice. Which test is not done? Not done in a baby. Which of the following test is not done in a baby who born to HIV positive mother? IgG antibody to HIV, because mother is positive. So IgG antibody will traverse into the baby. So baby Eliza will be positive. So which of the following test not done in a baby who born to HIV positive mother? IgG antibody based test. Eliza test not done in a baby. So which is the most sensitive test? HIV DNA assay by PCR. Hope I am clear in this. Clear? Clear? Which is the most sensitive? A is the most sensitive. Why Arush you put C? A is the most sensitive test. Answer this question. Late complement deficiency is an absolute indication for which of the following vaccine? Late complement C5 to C9 deficiency is an absolute indication for meningococcal vaccine. Meningococcal vaccine. So this sometimes ask, which is the absolute indication for pneumococcal vaccine? Pneumococcal vaccine. Nephrotic syndrome, sickle cell anemia, cochlear implant, CSF leak, skull fracture. These are the conditions where pneumococcal infections are more common. Nephrotic syndrome, pneumococcal peritonitis, most common complication. Sickle cell anemia, due to autosplenectomy, pneumococcal infections are more common. Cochlear implant, ENT surgeon make sure before putting a cochlear implant, patient should receive pneumococcal vaccine. Patient presented to you with CSF leak, skull fracture, which organism most commonly leads to meningitis? It is pneumococcal. Late complement deficiency, meningococcal. These 5-6 indications are pneumococcal vaccine. Answer this question. Read, try to make an answer. Three-month-old boy appear hypoglycemic, seizure, short stature, hepatomegaly, protuberant abdomen, and doll-like faces. Doll-like faces. Lab finding revealed hypoglycemia, lactic acidosis, hyperuricemia, hyperlipidemia. These 4 points are hallmark of a condition. Hypoglycemia, lactic acidosis, hyperuricemia, hyperlipidemia. Yes, this is von Wieck disease. Two things put stamp over it: hepatomegaly and doll-like faces. Okay, so yes, it is von Wieck disease. Glycogen storage disease type 1. It is due to liver became unable to break down stored glycogen. Liver became unable to break down stored glycogen. It is of two types, 1A and 1B. It is due to deficiency of glucose 6 phosphatase and glucose 6 phosphatase translocase. You need to remember von Wieck disease, glucose 6 phosphatase. Glucose 6 phosphatase. Remember this question as a theory. These 4 points: hypoglycemia, lactic acidosis, hyperuricemia, hyperlipidemia, doll-like face, protuberant abdomen. These fit into von Wieck disease. Sometimes we read alkaptonuria, homocystinuria, Tay-Sachs, Gaucher. Question come on von Wieck disease. So remember, yes, Arush, it's a classical history, classical case of von Cricket disease. Shall we move? Answer this question. Which of the following are multifactorial disorder? Which of the following are multifactorial disorder? First, you need to understand what is multifactorial. Where two or more gene. Two or more gene with additive effect of environment responsible for some condition. This is known as multifactorial inheritance. Multifactorial inheritance. Now see, one is Mendelian inheritance, X-linked autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. Another is non-Mendelian inheritance, which is not follow the Mendel's rule. Mitochondrial inheritance, triple codon transmission. One is multifactorial inheritance. Multifactorial inheritance. Two or more gene like hypercholesteremia, one gene, obesity, second gene, lack of exercise, alcohol, environmental factor leads to coronary artery disease. Leads to coronary artery disease. So sometimes we read so many autosomal sex link and we forget multifactorial disorder example. First, you remember this. Then what are the multifactorial disorder? Then we again come to this question. Multifactorial inheritance examples in children. Congenital malformation. Examples are neural tube defect, cleft lip and palate, pyloric stenosis, congenital dislocation of hip, Hirschsprung disease, congenital heart disease. Got my point? Why? This is the common question. Parent comes and asks, sir, why my child developed TGA? Why my child developed tetralogy of Fallot? Multifactorial. Some genes, some drug intake, some environmental effect, some chromosomal factor, multifactorial inheritance, not a single gene, not a single cause. So you need to remember congenital malformation, neural tube defect, cleft lip and palate, pyloric stenosis, congenital dislocation of hip, Hirschsprung disease, congenital heart disease. In adults, very simple, coronary artery disease. Once you remember, you will remember hypertension, asthma, epilepsy, diabetes, multiple sclerosis, rheumatoid arthritis, schizophrenia. These are multifactorial. Schizophrenia, not a single gene responsible. It's a multifactorial. Epilepsy, multifactorial. So my purpose to give you some topics which you need to read for your upcoming exams. Simple one, congenital malformations. In pediatrics, you remember this. Come to the question. Pyloric stenosis? Yes. Cleft palate? Yes. Neural tube defect? 1, 2 and 4. 1, 2 and 4. Who are right? Everyone is right. Smriti, Arush, Parth, Brinda, everyone is right. Pyloric stenosis, cleft palate, neural tube defect. Sickle cell anemia, autosomal recessive. Wilson disease, autosomal recessive. So which of the following are multifactorial disorder? This is my way to teach. All are live vaccines. Which of the following are live vaccine? With single question, multiple choice, you try to learn more things. This is not the exam. Now you can afford to wrong this question. But this is the best way to remember the things. To remember the things which are multifactorial disorders. 1, 2 and 4. Clear? Two or more gene with additive effect of environment responsible for some condition known as multifactorial inheritance. Congenital malformation, neural tube defect, cleft lip and palate, pyloric stenosis, congenital dislocation of hip, Hirschsprung disease, congenital heart disease. In adults, coronary artery disease, hypertension, asthma, epilepsy, diabetes, multiple sclerosis, schizophrenia, rheumatoid disorder, rheumatoid arthritis, multifactorial inheritance. Answer this question. Answer. I'm waiting for your response. Which of the following are multifactorial inheritance? Sorry. If mother is hemoglobin is A2 is more than 5 gram percent. If hemoglobin A2 is more than 3.5 gram percent, it indicate individual is carrier for thalassemia. Carrier for thalassemia. In our case, hemoglobin is more than 4.5 gram percent, means definitely mother is carrier for thalassemia. One thing to confirm carrier, to determine hemoglobin A2. Can anybody put in the comment box which test? Ask 2-3 times. Which test we do to detect thalassemia carrier? To detect thalassemia carrier. Which test we do to detect thalassemia carrier? Yeah, I am waiting for your answer. Nesterov test. Naked eye, single test tube, RBC osmotic fragility test, Nesterov test. By Nesterov test, what we are able to prove? Osmotic fragility decrease. So thalassemia carrier have two property. Number one, hemoglobin A2 is more than 3.5 gram percent, and number two, osmotic fragility decrease. Remember, but this is not solve our question. Our question is mother hemoglobin A2 is more than 4.5 gram percent. Father A2 is normal. This is mother. This is father. Mother hemoglobin A2 is more than 4.5 gram percent. So mother is carrier for thalassemia. Thalassemia is an autosomal recessive disease. If one gene is affected, carrier. Disease not manifest. It's a normal. You, me, anybody can be carrier for any autosomal recessive disease. This is carrier. Now see, this is the first possibility. X dash X. This is the second possibility. X dash Y. This is the third. XX. This is the fourth. XY. So these two are carrier. These two are normal. Thalassemia is autosomal recessive disorder which manifest in homozygous state. When both chromosomes are affected, then only disease manifest. If one is carrier, how disease will manifest? So, if one is carrier, another is normal, what percent of chance they have a thalassemia baby? 0%. Am I clear? If clear, put yes in comment box. Thalassemia or any autosomal recessive disease manifest in homozygous state. If one is carrier, one is normal. Homozygous is not possible, na? Homozygous is not possible. That's why it will be 0%. If one carrier, one normal, it will be 0%. Okay. Answer this. Albinism is autosomal recessive disorder. Autosomal recessive. Both parents are carrier. Mother, father. Mother be carrier or father be carrier. Now see, this is the first possibility. This is the second possibility. This is the third possibility. This is the fourth possibility. Both parents are carrier for albinism. What percent of chance they will have a albino child? Both are carrier. Now see, this is normal. These two are carrier. This is affected. Why I am telling this is affected? Albinism is an autosomal recessive disease. It manifests in homozygous state. When both genes are affected, disease will manifest. So, both are carrier, then chance of having a homozygous state, chance of being affected is 25%. Yes, you all are right. Answer is 25%. Both parents are carrier for albinism. What percent of chance they will have a albino child? 25% chance. 25% they will have a affected child. 25% they will have a normal child. 50% their child is a carrier. Clear na? Autosomal recessive. If one parent is carrier, homozygous stage is not possible. So next baby chances 0%. When both parents are carrier, chance in next baby is 25%. Little more. Answer this. I am waiting for your response. I wait for 30 seconds at least. Mother and father both are achondroplasic. This question come 3 times. 2 times in NEET, 2 times in AIMS, 1 time in NEET continuously. Both are achondroplasic. When this question comes first time, na, they didn't know achondroplasia is autosomal recessive or dominant or X-linked or dominant. The best way, simplest way, you remember the things. Dominant disorder, spelling of dominant. You will never forget in your exam or lifetime. Dominant, these are the dominant disorder. D for dystrophy myotonica. O for osteogenesis imperfecta. M for Marfan syndrome. I for intermittent porphyria. N for Noonan's syndrome. A for achondroplasia. N for neurofibromatosis. And T for tuberous sclerosis. So these are dominant disorder. These are dominant disorder. If you remember this, you can easily pick out achondroplasia is a autosomal dominant condition. Achondroplasia is a autosomal dominant condition. Now, both parents are achondroplasic. Achondroplasic in circus, we saw the Daphne. Those are the example of achondroplasic. So, mother also achondroplasic, father also achondroplasic. Achondroplasia is the autosomal dominant disease which manifests in heterozygous state. Means if one chromosome is affected, disease is going to be manifest. Disease is going to be manifest. Both parents are achondroplasic. What percent chance they will get a normal baby? Now see, x dash, x dash, x dash, y, x, x dash, xy. Now see, this is normal. This is affected because achondroplasia is the autosomal dominant. If one of the genes affected, disease will manifest. And this is severely affected. Itna severely कि this baby will die in utero or early infancy. Our question is very much clear. Mother and father both are achondroplasic. They have a chance 25% they will have a normal baby. Now, lot of you are putting 0%. I got your mind. I got your what you are thinking. Suppose we write here X double X. Both are affected. So why can't we write here? No. In autosomal dominant condition, if homozygous stage occur, this is lethal. It will not survive. They will die in utero or early infancy. It will not survive. This stage is lethal. So if we are talking about mother and father, means they are alive till 20-25 year. So it's presumed they are heterozygous only. Heterozygous only. So mother and father both are achondroplasic. What percent of chance they get a normal baby? It's 25%. So I try my level best to give you three classical question of genetics. Mother and father, mother carrier, father normal. One of them is carrier, another is normal. Homozygous stage will not possible. Next generation chance 0%. If both are carrier, homozygous possible in 25%. This is about autosomal recessive. Now come to autosomal dominant. Mother and father both are achondroplasic. Means both are heterozygous. What percent of chance? Simple math, simple thing. You need to make a pedigree. XX, XY. Okay. So what is there? Both are achondroplasic. 25% chance they will give birth to a normal baby. And this is a practical scenario. Why genetics help us? Just few, just when the COVID is over, I was sitting in my OPD. One achondroplasic couple comes in my OPD. They are both are deaf, husband and wife. They come with a 1-month-old baby. So they want to adopt this baby. So I asked them, how long you both are married? So they tell 6 months. Why you are want to adopt a baby? Sir, as we both are achondroplasic. Listen. Sir, we both are achondroplasic. To have a normal baby, chance is only 25%. 75% we have a achondroplasic baby like us. And that too, as my wife is achondroplasic, so normal delivery is not possible. We need to do a cesarean section, and I can't want to take that risk. and we don't want our babies like us. So that's why we are adopting a child. Genetics. Okay, mother and father both are achondroplasia. What percent of chance they will get a normal baby? 25%. So here I try my some best to give you best of questions in neonatology, genetics, and basic pediatrics. So this is about YouTube class. Two more, one tomorrow and another on 27th August. Two more special classes on Unacademy app. So please connected and watch these good MCQs. Yes, I am taking a plus course in next. So these neonatology, general pediatrics, systemic 1, systemic 2 we have covered. Now we left with systemic 3, image based and previous year. Those who are plus student can watch this me on daily live 7:30 to 9:30. So that's all from my side. If you like, share with your colleagues, your juniors. Thank you. Bye bye. God bless you all. God bless you all. Thank you.